So dear postgraduates, so today's topic will be on COVID-19. So you all know that WHO has declared the new coronavirus outbreak as a public health emergency of the international reputation. So I have seen so many cases of the COVID-19 in those days, and really a nightmare for most of our doctors in general and in public in particular. So a lot of the jokes were there at that time. అందరూ గాంధీ ఆసుపత్రి పరిగెడుతున్నారు. It's not because of Kareena Kapoor or Katrina Kaif. So don't go anywhere. It's all because of coronavirus. So you have seen the long-term effects of the COVID-19. Okay. So nearly 80% at least one symptom. A lot of the people are had fatigue, headache, attention disorder, anosmias, memory loss, hair loss, hearing loss, tinnitus, nausea, breathlessness, cough, okay, chest discomfort, chest pain, etc., arthralgias. So you name any system in the body, and most of the systems are involved in the long COVID or post-COVID sequelae. And if you see an X-ray, abnormal chest X-ray was seen nearly the 50% of the patients. And there was even today, some of the population, they are having the elevated D-dimer levels more than the 500. NT-proBNP was positive. CRP was always elevated more than the 30 or more than the 40, 60, 100. Ferritin levels were elevated. Procalcitonin, that was also elevated in some individuals, and interleukin 6. See, if you see these investigations, these are all very, very important investigations. We need to get it tested for all the COVID population. See, what is the pathogenesis of this long COVID-19? So maybe could be because of one of these three reasons. One is the viral injury. Sometimes it is the neuroendocrinal disorders. And sometimes maybe the immunological defects. See again, in the brain, in the neuroendocrine centers, in the heart, in the lungs, in the liver, in the vessels, in the skin and subcutaneous tissue, myalgias, arthralgias. So the lot of the things are involved here, and will come at a later time as and when required. So general principles were that clarify the treatment of the drug, reduce the viral load, and reduce the injury. Anti-inflammatory and immunopathological injury, you have to reduce it and correct the hypoxia. A chronic hypoxia is again related with a lot of the pulmonary hypertension or heart failures, and improve the blood coagulation. Exercise is very important. Physical activity is very important in this population, and good oxygen therapy. And then the photobiomodulation therapy, psychological interventions, and sometimes meditation or antipsychotic drugs, and rehabilitation mechanisms like immunomodulation, antioxidants therapy, or neuroendocrine regulations. See, you all know that the ACE2 receptors, so that is where this virus attaches to your type 2 pneumocytes. Then the infection and the immune response starts there. First, there will be the high fever, then the cough, then the breathlessness, chest discomfort. So mostly the respiratory symptoms will start initially, and later at the level 1 and the level 2, and almost all the organs in the body will be involved. So the most of these people will be having the cognitive impairment, easy fatigability, asthenia, and lot of the secondary infections are mostly streptococcus pneumoniae and all other bacteria, viral, fungi. So everything will be involved here because of the immunodeficiency disorders. And mental health conditions, the depression, agitation, lack of interest, concentration, lack of concentration, sleep disturbances. So these are all very much involved in the post-COVID and the long-COVID population, and a lot of the economical loss, isolation and unequal access to the green space exacerbates the disease, and mental health is also very important here, and some of the people are on social isolation and the reduced exercises. So these are all the common symptoms we see in the long COVID: fatiguability, breathlessness, chest pain, brain fog, that is the problems with the concentration and the memory, insomnia, palpitations, dizziness, tingling and numbness sensations, arthralgia, mood changes, depression, anxiety, tinnitus, diarrhea, abdominal pains, cramps, so gastrointestinal symptomatology, loss of appetite, changes to the sense of the taste and the smell, so there will be anosmia, anorexia, chronic fever, cough, headache, maybe the vascular headache or tension headaches, rashes, and there were the menstrual abnormalities. So these are all very, very common long-term symptoms in the long COVID or the post-COVID sequelae. The same things here, something concerned with your lungs, something concerned with the brain, heart, and in general. So a lot of what are all the symptoms I told you right now. So they are all because of these pro-inflammatory state, the production of the reactive oxygen species, and more cytokines, abnormal coagulation, increased risk of the thrombosis, pro-fibrotic states, and then the parenchymal infiltration by the leukocytes and the cytokines, a chronic neuroinflammations, chronic neuronal damage, autonomic dysfunctions. So these are all the different pathophysiological mechanisms by which a long COVID symptoms will occur in most of these individuals. And a lot of the difference between the children, adolescents, and adults. We are very much interested in the adult practice. Here, there are 1% asymptomatic adults, whereas 99% they are the symptomatic. And if you see the symptomatic, about 20% they are the very severe, and nearly 80% is the mild. If you see the children and the adolescents, they are the good people, they are the fortunate people that asymptomatic to the tune of about 6%. Even though they are symptomatic 94%, 99% is a mild, only 1% severe. So that is the major difference between the children and the adolescents when compared to the adult practice. Here in our specialty, nearly 20% are very severely involved. And if you see the post-COVID-19 sequelae, about 10 to 61%, they had one or the two or the many symptoms what I have told you right now. These people will be having that in the adults in our practice. Whereas in the children, it is only 1 to 30% have the post-COVID-19 the conditions. So the children and adolescents when compared to the adult practice, so we are very much involved in this COVID treatment, because a lot of people are the severe, and nearly 61% of the people they have the post-COVID-19 sequelae. See the coronaviruses, the zoonotics, that means they are transmitted between the animals and the people. You have the SARS, that is severe acute respiratory syndromes. We have the MERS, etc. So these are all transferred from the animals to the humans. They are the zoonotics. So we are very much interested in this China virus. First started the cases in Wuhan. That is a novel coronavirus. So the earlier viruses, they have taken the mutations in the animals, and then the new coronavirus have occurred, and that is the main reason for this transmission of these COVID-19 cases. It believed to have a jump from an animal species to the humans in a seafood and a wildlife market in Wuhan, China. The source, transmission, and mutation methods were not known, and symptomatology mostly the respiratory symptoms. They started with the fever, cold, cough, breathlessness, and then suddenly they need hypoxia, and then the admissions. So the first case between 25th of December 2019 to 30th, it was in China. Cases linked to a seafood market in the Wuhan city. And within the 1 week, a lot of the cases in the same market area. So they have contacted from the human to the human. And a lot of people are getting infected with this new coronavirus. And within the next week, the China could isolate this virus. So this is not a simple virus like your SARS or your MERS. It's a different virus. They have taken the mutations in the animals. And then they have found that the genomic proposition, genomic structure of this new coronavirus, they consider as the COVID-19. And then they started manufacturing the kits also for the proper identification of this virus. And you all know that immediately within the 10 days or the 15 days or within the 1 month, a lot of the cases were identified, not only in the China, outside the China also. In fact, the first case in India is from the Kerala, isolated from the Kerala, a medical student who has come all the way from the China. He got infected with this coronavirus. So how quickly has it spread? In a tsunami proposition, very high numbers. So maybe not the thousands, maybe the lakhs and crores of the population in India and also in the world, they have infected like anything. China shares the information to mark the diagnostic kits. Already I told you that genetic sequence of this novel coronavirus very, very fast. So in the last week of the 2019, they first identified the case. Within the first and second weeks of the next year, the 2020, so they identified these genetic sequences and of great importance for other countries to use in the developing specific diagnostic kits. So I achieved a great success in some of these viruses, including the polio, but we could not make a great success in coronavirus because it has killed a lot of individuals all over the world, especially the young individuals. Why the viral infections are difficult to treat? Because the viruses are inherently difficult targets. They have in general smaller genomes than the bacteria. So there are fewer places to look for ways to combat them. And many drug molecules do not reach the targets to control the spread and the growth. So unlike the bacteria, so it's very, very difficult to control the viruses because they have very smaller genomes than the bacteria. These are the global examples of the emerging and the re-emerging infectious diseases. So a lot of the infections are there here, like West Nile virus or Ebola hemorrhagic fever, drug-resistant malaria, H1N1 influenza, adenovirus, dengue, yellow fever, and then the typhoids, Rift Valley fevers, E. coli, Nipah virus, chikungunya, monkeypox, Lyme disease, hepatitis, HIV, Lassa fever. So these are all the emerging viral diseases all over the world, and unfortunately, so any viral disease anywhere in the world, India will be the one of the important countries to get infected and to have a lot of the cases because of the air travel. The clinical manifestations of the coronavirus infections. So these are all flooded. Almost all the ICUs in India are flooded with these cases in those days. The common signs of the infection include respiratory symptoms, fever, cough, shortness of the breath, and breathing difficulties, hypoxia. In more severe cases, infections can cause pneumonia, a septic shock, severe acute respiratory syndromes, ARDS, etc., acute kidney injury, and even the death is also possible in most of these coronavirus infections. So even though they start like a respiratory tract infections, and within no time, they cause viral myocarditis, they cause acute kidney injuries, they cause encephalitis, they cause septic shock, and finally the death. Mild disease, uncomplicated upper respiratory tract viral infections. Most of these cases, as an outpatient or with a quarantine period, they get recovered by themselves. So that is the mild illnesses. Fortunately, a lot of the people are there. About 70 to 80% are mild cases. Moderate pneumonia, Here the pneumonia without the need for the supplemental oxygen. So no hypoxia, pneumonia, they need some secondary antibiotics and then some maybe the virus, steroids, and then they fare well. In severe pneumonia, pneumonia with dyspnea, with hypoxia, so they need oxygen therapy. And the critical illnesses is the multi-organ failure, so definitely they need ICU setups and then intensive care. Why new viral infections are emerging? Because of our close proximity with the animals, human beings. See, the new viral diseases that typically emerge because of the human activity that brings people into contact with the wildlife, such as the road buildings, hunting, and agricultural expansion. About 75% of the emerging diseases in the people come from the animals, according to the Eco Health Alliance. The incubation period here is 4 to 5 days. So maximum is the 14 days. 2 weeks is the maximum period. There are 7 coronaviruses strains are there, and we are interested in the novel coronavirus, that is 2019, and earlier we have the MERS and also the SARS. So these are the differences between your classical 3 viruses. The center one is the SARS, that is severe acute respiratory syndrome, identified in 2003. First case again in the China. Here nearly the 650 people were killed in China, Hong Kong, and here it is spread from the bats to the animals. And then you will have the first one, MERS, the Middle East Respiratory Syndrome. Here the first identified in Saudi Arabia in 2012. Nearly 800 people were killed there. Here the transmission is from the camels to the humans. And the last one is the new strain, that is our coronavirus, novel coronavirus 2019, identified in Wuhan, China. Hundreds, thousands, lakhs of the cases are detected in China, and also the number of the deaths there. Seafood or animal market is the center of the outbreak. Human to human transmission is the most important way of transforming here and all over the world. And if you see the structure, envelope, non-segmented, single-stranded RNA virus, the crown like the spikes on the outer surface, major structural proteins, a spike at the surface glycoprotein called as the S proteins, and E is the envelope protein, and M is the membrane protein, and N is the nucleocapsid protein. So surface protein, envelope protein, membrane protein, and nucleocapsid protein. So this is the structure of your novel coronavirus. Membrane proteins, spike proteins, nucleoproteins, genomic, single-stranded RNA, and this is how it looks like. Spike glycoprotein, this is very, very important because it helps in binding of the virus to the host cell with the ACE2 receptor enzymes. Okay, cleaved by the host enzymes into the 2 subunits, S1 and S2. S1 virus host range and cellular trophism with the receptor binding domain. S2 helps in fusion of the virus with the host cell. There the furin protease sequences at the cleavage site, which are the characteristic of the SARS-CoV-2. So this is something about your spike glycoprotein. Here the membrane protein, a shape of the virus envelope, stabilizes the nucleocapsid and promotes the viral assembly. Nucleocapsid protein, it enhances the affinity of the virus. The envelope protein, the production and maturity of the virus. So that is how these 4 proteins will help in transforming this virus into the diseased one. The genome, here the sequence is 26 to 32 kbb, contains 14 open reading frames which encodes for 27 proteins. So this is the structure really. So in the RT-PCR they study all these things. So this is the important slide, shows you the uninfected individual, a moderate COVID-19 individual, and a severe COVID-19 individual. తీసుకుంటాడు. In uninfected individual pulmonary epithelium, see here in the circulation CD4 cells, CD8 cells, and there were no symptoms. So that should be there like that for the normal individuals. Okay. See what happens to your moderate COVID-19. Here the SARS COVID-2. See the epithelium, pulmonary epithelium in the center one. So there is already damaged epithelial cells. See the change of the color of these cells. Once the cells are damaged, this coronavirus will enter into the inside. So inside they will attack the macrophages, then the chromonecros, TNF alpha, then your interleukins 6 and the 10, and there will be elevated cytokine levels. So you see here at the center level you have the CD4 and CD8 T cells. So they are reducing the number. So that is the reason in the early period of your COVID you will have leukopenia and you will have lymphopenia. So the WC cells will be reduced and the lymphocyte count will be reduced. So that is the most earliest things will happen in your CBP in COVID early hours. And whatever the symptomatology, the people will have the respiratory symptoms like fever, cough, fatigue, myalgia, etc. And interleukin 6 will be elevated and there will be lymphocytopenia. CD4 T cells will be reduced. CD8 T cells also will be reduced. So at this juncture, most of the people will survive. But what will happen when they have the severe COVID-19? So we are very much interested in the last part. See here, the damaged epithelial cells are very increased in the number and there will be the cytokine storm. So the more and more cytokine levels, like your TNF alpha, your interleukin 6, 10, etc. See the number of these cytokines very much increased. So they damage each and every cell in the body. And what about your CD4 cells, CD8 cells? They are in very much reduction in the number. And now the fever, not only the fever, almost all the symptomatology will be there. The fever, cough, fatigue, myalgia, dyspnea, ARDS, respiratory failure, etc. And increased interleukin 6, increased LDH, increased D-dimers, procalcitonin, CRP, ferritin, so interleukins. So these are all very much elevated. Okay. And then what about the cells? So there will be leukopenia, lymphopenia, and also your CD4 and CD8 cells will be reduced. So that is how they happen. Once they get the secondary infection, then the WBC count will start increasing. So that is leukocytosis. So earlier leukopenia, at a later time leukocytosis indicates that this fellow had a secondary bacterial infection where you have to use very good antibiotics, maybe preferably a third generation cephalosporin or meropenem, etc. So after entry, the binds to the ACE2 enzyme presents on the type 2 pneumocytes with the spike protein. So that is here the spike protein is important. Type 2 pneumocytes are important. They are at the alveoli level. So at the peripheral level in the lower lobes. So that is the reason if you see the picture in the lungs, it is mostly the peripheral lungs involvement, lower lobes involvement, and then the distal alveoli will be involved in the COVID pictures. In S1 subunit attachment, S2 fusion with the host cell membrane. Pathogenesis involves the virus replication, host immune response. ACE2 also present in the enterocytes, kidneys, and the heart. So ACE2 not only in the pneumocytes, but also in other places also you will be having the ACE2. So that is the reason COVID-19, not only your respiratory tract, but also the other organs also will be involved because of the presence of the ACE2 in some other place. See the heart, so that will be a myocarditis. In the kidneys, acute kidney injury. In the enterocytes, you have the gastrointestinal symptomatology. See the same picture here, the attachment and the entry are spike proteins, encoding, see the RNA, See the exocytosis and the virus release. So these are all the pictures will occur in your respiratory tract. See here, there will be the excessive immune response. You know the cytokine storm. Then the local and the systemic inflammatory response. So systemic inflammatory response will be there. Okay. So because of here, you will have the two things will appear. One is hypercoagulability and the second thing is endotheliopathy. So there will be endothelial dysfunction, leads to a lot of the vascular injury, and here the hypercoagulability. So the imbalance of the procoagulant versus the anticoagulant proteins. In the endotheliopathy, switch to a procoagulant phenotype to the injured endothelial system, vasoconstriction. Because in endotheliopathy, you will have a reduced nitric oxide. So the nitric oxide is a potent vasodilator. So once the vasodilator nitric oxide is reduced, so these vessels will have the vasoconstriction. So the vasoconstriction will lead to a lot of vascular injury. So here the activation, the platelets, leukocytes, monocytes, okay, fibrinogen levels, increase the thrombin generation, increase the D dimers, fibrins, etc. So all this will lead to hypoxia. So in both the hypercoagulability and your endotheliopathy will lead to the hypoxia. And then there will be both the microthrombosis and the macrothrombosis. So then the microthrombosis, a multi-organ failure, maybe your retina will be involved, your kidneys will be involved, your liver will be involved. These are all the microthrombi. So the macrothrombus, so the venous thromboembolism, or your myocardial infarctions, cerebrovascular diseases, or peripheral vascular diseases, or renal artery stenosis. So these are all the macrothrombus. Okay. So finally the people will have the pulmonary embolism, ARDS. So this is all the picture, which is a continuous process in the COVID-19 cases. See, there are a lot of the things here. One is the fusion, that is the one, and then there is the translation, then the proteolysis, then the translation and RNA replication, packaging, virion release, endocytosis. So these are the different mechanisms which occur in inside the cell, inside your pneumocytes, or inside your enterocytes, or inside your renal cell, or inside your neurons. So all these things will occur, and you have some of the drugs also which act against different things. For example, the remdesivir. See the remdesivir here. So that acts at the level of the RNA dependent RNA polymerase. It's an antiviral drug. So which acts on your genomic. So single stranded RNA. So the remdesivir will act there. Suppose if you want to use these lopinavir and ritonavir. So here the polypeptide chains and the translation. So there it acts. Again, we use a lot of the drugs like vitamin C, vitamin D, zinc, hydroxychloroquine. Okay. So the lot of the drugs we used in these things, and the steroids we used, tocilizumab we have used, remdesivir we used. So these are the different drugs which act on these things. So the measure the SARS-CoV virus 2 with the spike proteins. So the act here is the vitamin C and the vitamin D, maybe the non-specific actions. Yes, potentially detrimental, ARBs beneficial or the risky. Baricitinib that inhibits the ARC1. Okay. The cellular mechanism, synthesis, viral proteins, secretes them. Immature viral spikes. Tocilizumab via interleukin 6 blockade. Other anti-cytokine therapies reduces the cytokine storm. So when the fellow in the multi-organ failure, when the IL-6 is very much elevated, then we have to use the tocilizumab. So this is reduces your cytokine storm. So these are the risk factors, especially the elderly population, people with diabetes, hypertension, ischemic heart disease, COPD, CVA, CKD, heart failure, immunocompromised, malignancy, on chemotherapy. So these are all the different people who are at high risk of getting this disease, and also most of these people, they succumb to death. So the most important reason of the death in COVID-19 is because of these comorbidities. Transmission high in the first week of the disease, more load is present in the upper respiratory tract, seen even in the asymptomatic individuals, person to the person direct contact because of the droplet spread, fecal-oral transmission, and airborne. So the clinical features, the incubation period I told you, usually the 4 to 7 days, but it may extend up to the 14 days. Common is the fever, about 90%, cough, nearly 70%, disturbed taste under the smell. This is a very peculiar in the COVID-19 virus. So anosmia and ageusia, so that is the loss of the smell and loss of the taste, fatigue, myalgias, sputum production, hypoxia, sore throat. So these are the common symptoms we often see in the COVID-19. The fever in more than 90% of the cases, dry cough 80%, shortness of the breath 20%, respiratory distress in 15%. The vital signs were stable in most of the cases, while leukopenia and lymphopenia, they were the common, and they were seen in the early stages of this disease. Older adults and the people who have severe underlying chronic medical conditions like heart or the lung diseases or diabetes seem to be at a higher risk for developing the more serious complications from 19 illness. It is not that rare. Usually we have seen the nausea, vomiting, nasal congestion, diarrhea, palpitations, tightness in the chest, hemoptysis, confusion, seizures, paresthesias, altered consciousness, strokes. So these are all very common presentations of COVID-19. They can be divided into the 3 groups: mild, moderate, and the severe. In the mild, so these are the common presentations, mostly the respiratory symptomatology and clinical features, no hypoxia, and managed at the COVID care center as an outpatient basis. In the moderate, so these people will have the pneumonia with no signs of the severe disease, no hypoxia. Child, adolescent, adult with dyspnea and or hypoxia, fever, cough, SpO2 less than the 94% on the room air. Respiratory rate is less than 24. So even these people also can be managed at the dedicated health center. But these are the very important people. They need the admissions and the intensive care. Severe pneumonias. The signs of the pneumonias with respiratory rate more than 30, SpO2 less than 90 on the room air, central cyanosis, inability to breastfeed or the drink, especially in the children and the neonatologists, lethargies, unconsciousness, convulsions, and ARDS, sepsis and septic shock. So these are the features of your severe COVID-19 infections. Most patients had mild to moderate disease, luckily, but nearly 20% had severe and the critical illness. See the mild and moderate, nearly 81%. So 100% recovery. Severe, about the 14%, and critical 5%. So we lost a lot of these people in between this severe and the critical period. Okay. So in a country like India, 140 crores population, spreads like anything, can imagine the number of the critical cases and the severe cases in Indian population. Case fatality is disproportionately higher among the elderly individuals. See the case fatality, the fatality rate is high once they cross the age more than the 50 years, or 55 to 64, 65 to 84. So the fatality rate was very, very high. So the younger individuals, no fatality, but beyond the 50 or 55 years of age group, more. More likely to require the ICU care and the die, but hospitalizations and ICU admissions also occur among the non-elderly adults. See again here the admissions, if you see here, between the 55 and the 65 years age group, more hospitalizations, more admissions, and more deaths. Same way between 65 to 74 years also. More admissions, more ICU admissions, and more deaths. These are the chronic conditions. They are higher in the hospitalized than in the non-hospitalized patients. They are the diabetes, COPD, cardiovascular diseases, immunocompromised individuals, and the CKD population. COVID-19 case fatality is the highest among the persons with underlying the medical conditions. So these are the underlying medical. So as a physician, so we often see these cases like, so the people with cardiovascular diseases like IHD or heart failure, people with diabetes, people with COPD, asthmatics, emphysematous, etc. People with cancers, so on oncology treatment. So these are the people at high risk of infecting these infections, and also the fatality rate is also very high. So here the fever, a cough, and breathlessness, they are the very, very important symptoms for the admissions. Coronavirus infection makes everyone scary. So the diagnosis. So the diagnosis is very easy at that time. Suspect the case. For example, a patient with acute respiratory symptomatology, like you are this fever, cold and cough or breathlessness, etc. And history of the travel or the residence in a location with a community transmission. So obviously you are dealing a case of the COVID-19, obviously. Okay. Otherwise, a patient with acute respiratory illness, so all the respiratory symptomatology, and having been in contact with a confirmed or a probable COVID-19 case in the family or in the friends or in the hospital or in the working place. So again, definitely a case of a COVID-19. Or a patient with severe acute respiratory illness. Symptoms of the respiratory diseases, a cough, breathlessness, fever, etc. And in the absence of any alternative diagnosis. The patient is in the severe respiratory symptoms and no other cause was there to diagnose this case. Again, most probably you are dealing a case of COVID-19. RT-PCR is a very, very important investigation, highly specific and sensitive, about 90 to 95% of the cases. Specimen is preferred is mostly the nasopharyngeal or the oropharyngeal swabs. If high clinical suspicion and a negative for the upper respiratory samples, so better to get the lower respiratory tract samples collected, maybe the sputum or the ball. In severe diseases, blood cultures prior to the antibiotics, because sepsis and septic shock is very common in severe COVID-19. So blood cultures are very much needed. Antibody testing is not recommended currently. So this is an important slide to be known that the three values here, RT-PCR, IgM and IgG. See, RT-PCR is positive, IgM and IgG are the negative. So that means the fellow is in the window period. Okay, patient may be in the window period of the infection. So the most earliest phase is RT-PCR positivity, but IgM and IgG will be the negative. PCR positive, IgM is also positive, IgG negative. So that means the patient may be in the early stage of the acute infection. All the three are positive, RT-PCR, IgM and IgG. The patient is in the active phase of the infection. Here the PCR is positive, IgM is negative, IgG is positive. So the patient may be in the late or the recurrent stage of the infection. So G means a protective. Okay. Now the PCR is a negative, IgM is positive, IgG is negative. Here once the IgM is positive, the fellow is in the acute infection. Here the PCR negative may be the false negative. Okay. And another case, PCR is negative, IgM is negative, IgG is positive. That means recovered well post-infection. Okay. So it's not an acute infection. Here the RT-PCR is negative, IgM positive, IgG positive. So that means he crossed the endo period. He is in the active infection. At the late stage of the active infection, already IgG also started coming in. So he is out of the danger. Okay, because IgG is positive here. The patient may be in the recovery phase of the infection, or the PCR result may be here the false negative. So this interpretation you should be very much familiar and should be one corrected. Okay. So according to this RT-PCR and IgM and IgG, so you can know whether the fellow is in the window period, or in the active infection, or in the late infection, or in the recovery infection. So these are the very important. See, RT-PCR is currently being used, expensive at that time, takes longer period, more than the 5 days, 6 days also they used to take it. In the early days, all the specimens were sent to the Pune, and later we have the regional labs, one at Vijayawada, one at Kakinada, one at Rajahmundry, etc. And the antibodies, there's a very, very cheap with the strip test, okay, but they are very quick also, but false reports were very high in the early stages. Corona testing positivity rates, bronchoalveolar lavage fluid, positivity is 93%, but it's not possible to get the bronchoalveolar lavage in all the population. Fibrobronchoscopic brush biopsy is a 46% positivity. Sputum, 72%. Nasal swabs and the pharyngeal swabs. These two are very, very easy to get it test done. So they are about the 63% is the nasal swab, and the pharyngeal swabs about 32%. Feces 29%, blood 1%, urine 0%. So nasal swab will detect only 2/3 of the cases. Pharyngeal swabs will detect only 1/3 of the cases. Nasal swab testing is better of the two for the unadmitted patients. Coming to the complete blood picture, decreased counts. So there will be the lymphopenia, leukopenia, thrombocytopenia. There will be elevated the liver enzymes, SGPT, SGOT, or bilirubin, or your alkaline phosphatase. So they will be elevated. PT will be elevated. INR will be elevated. RFT, in acute kidney injury, urea will be elevated. Creatinine will be elevated. So there will be the hyponatremia or hypernatremia or hypokalemia, hyperkalemia. So there will be dyselectrolytes. Ferritin levels usually elevated. D dimers were elevated. Procalcitonin was elevated. Okay. Chest X-ray is a very important investigation. So other than the chest X-ray, directly we get the CT thorax to know the CORAD score, etc. Lower respiratory specimens may have a higher virus yield than the upper respiratory tract specimens. See the co-infections. The sporadic viral co-infections are reported like influenza and parainfluenza. So sometimes COVID-19 plus H1N1. Community acquired secondary bacterial infection not reported in the published case series. Lab abnormalities in severe disease. Reduced lymphocytes, elevated neutrophils. Increased SGPT, SGOTs. LDH will be elevated. CRP, ferritin levels. Pro-inflammatory cytokines like interleukins, CRPs. Associated with the mortality, increased D dimers and the lymphopenia. Leukocytosis, specifically neutrophilia, during the hospitalization associated with the death. See here the non-survivors and the survivors. Survivors, the WBC count is within the normal limits. When there is a leukocytosis, so the more the chances of death. In the same way, the neutrophils also. So the more the neutrophils, more the chance of the infections and the death. Lymphopenia. See again, the lower the lymphocytes counts are associated with the severe disease and the non-survivor. D dimer, directly proportional to your mortality. Chest X-ray may be normal in the early and the mild diseases. 69% had an abnormal chest X-ray at the time of the admission. 80% had a radiographic abnormality sometime during the hospitalization. Findings are most extensive about 10 to 12 days after the symptom onset. So usually in the second or third week. The most frequent findings are the consolidations and the ground glass appearances. Here the distribution is mostly bilateral, peripheral, and a lower zone. So these three are very important. Mostly the peripheral, bilateral, lower lobe involvement. Here the consolidations and the ground glass appearances. Pleural effusions is rare. See the picture here. See the mostly the peripheral involvement, a bilateral involvement, lower lobe involvement. Again here on the same. Upper lobes are spared here. HRCT is the most important investigation of the choice in those days. Ground glass opacities, they are the multifocal, they are the peripheral, they are the bilateral, consolidation, crazy paving pattern, the thickened interlobular and intralobular lines in combination with the ground glass pattern, traction bronchiectasis, and bronchoalveolar dilatations. So these are all the features in the HRCT. Ground glass appearances, crazy paving patterns, and bronchiectasis. So very common here. See the peripheral ground glass appearances here. Bilateral. Here it is the crazy paving pattern. CORADS. It's a categorical assessment scheme used for the reporting the chest CT suspected to have the COVID-19. It represents the level of the suspicion of the pulmonary involvement. CT severity score. So each lobe maximum score is the 5. We have the 3 lobes on the right side and the 2 lobes on the left side. So the final score is 25. So each lobe maximum 5 points. Suppose if the lobe is involved less than 5%, your score is the 1. The lobe is involved 5 to 25%, score 2. 25 to 50% involved, it is score 3. 50 to 75%, 4. More than 75%, it is the score 5. So each lobe, here the 5 points. So like that, you will have a 25 points. What is CORADS 1? Normal or non-infectious abnormalities. CORADS 6, once the PCR is positive, irrespective of these CT findings, that is the CORADS 6. CORADS 2, abnormalities consistent with infections other than the COVID-19. 3, equivocal findings. 4, abnormalities suspicious for COVID-19. And 5, a typical COVID-19. So most of the times we use it to have either CORADS 5 or the 6. Here is the mild, less than the 8. 9 to 15 is the moderate. More than 15 is the severe. So they use it to give 8 by 25, 15 by 25, 20 by 25, 25 by 25, so etc. What are the elements of the standard precautions? Hand hygiene is the very, very important. Respiratory hygiene, your masks, according to the risk, PPE, safe injection practices, shot managements and injury prevention, safe handling, cleaning and disinfection, environmental cleaning, safe handling and the cleaning of the soiled linen and waste management. So these are all the PPE for use, face mask, N95 mask, face shields, goggles, gown, apron, gloves and head cover. The same things here. Okay. So in the mild cases, WHO guidelines, a symptomatic treatment like your paracetamol or bed rest, lot of the fluids, etc. Adequate nutrition and the hydration, no IV fluids, no admissions. In moderate cases, a symptomatic treatment again, oxygen supplementation provided if the fellow is in hypoxia. Adequate nutrition, the hydration. Watch for the signs of the deterioration and the disease progression. This is the very important moderate cases. So watch for your complications. So wait and watch is very important for your moderate cases. In severe cases, so definitely they get admitted in the ICUs, symptomatic treatment, good antibiotics, good oxygen supply, fluid management, okay, respiratory failure management, shock management, and antibiotics as and when required according to that. Suppose if the patient is also a diabetic, a good insulin therapy. If the patient is an hypertensive, so definitely a good antihypertensive medications. Or heart failure, again anti-failure managements. COPD or bronchial asthma, etc. Again the inhalation, nebulizations, etc. Or the patient is an anemic, so I have to correct the anemia. So these are the very severe cases, especially most of the people they are aged more than the 50 and the 60 years age group. Are the not only your respiratory care, but also the treatment of your comorbid is also equally important in these cases. Mild ARDS is high flow nasal oxygen or non-invasive ventilation, CPAP or BiPAP. In severe ARDS, endotracheal intubations, mechanical ventilations with low tidal volumes and the low PP. Prone ventilation is very much needed here, and conservative fluid management therapy. Shock, so you have to give the vasopressors like norepinephrine, etc. If shock persists even after the fluid resuscitation, a empirical antibiotic should be administered within the first 1 hour. So detailed history on the comorbidities, about the comorbidities. Paracetamol, antitussives for cough suppressants, nutrition and appropriate hydration. That is for your mild cases. Here the hydroxychloroquine, 400 milligrams BD on the first day, and then the 200 milligrams BD for the 4 days for the high risk individuals. So we usually give the hydroxychloroquine for about 5 days to the 7 days. So the kit, it contains hydroxychloroquine, ivermectin, vitamin C, zinc, paracetamol, etc. And also some antibiotic like doxycycline or azithromycin. Anticoagulation, here the prophylactic dose of the ultrafiltrated heparin or low molecular heparin, enoxaparin 40 milligrams per day subcutaneously. So these are for the moderate cases. Steroids are very, very important. Here the methylprednisolone we used, and also we used the hydrocortisone, we used the beclomethasone, we used the simple prednisolone. So what are all the different compounds of these there? But once the patient is admitted, the patient is in the severe, so definitely methylprednisolone scores over the other drugs. So we used in the doses of 500 milligrams or the 1 gram also, either OD or the BD. Dexamethasone is a simple drug and the cheap also, 0.1 to 0.2 milligrams per kg body weight for 3 days. Within 48 hours of the admission, or if the oxygen requirement is increasing and inflammatory markers are increased. Comorbid conditions, one have to treat it, and good antibiotics, empirical antibiotics once the patient is in having the leukocytosis or neutrophilia. So anticoagulation is very much needed, low molecular heparin, steroids, adequate fluid therapy, and once the interleukin 6 is also involved, so again you have to give the tocilizumab also here. ARDS, the ventilations, your CPAP and BiPAP, etc. And invasive medical mechanical ventilation, intubations. So they are very important. So we take the help of the intensives here. So same thing here. ECMO in some cases. We have the refractory hypoxemia. Despite the lung protective ventilation, a prone ventilation. Shock. So give the vasopressors. Isotonic crystalloids here, like your albumin, norepinephrine, when the shock persists during or after the fluid resuscitation, and good antibiotic therapy. Remdesivir is a very, very important drug and may be considered in patients with a moderate disease. It is, in fact, the first antiviral drug useful in the management of the COVID-19. But some contraindications like AST and ALT more than the 5 times, acute kidney injury, pregnancy and the lactating females, less than the 12 years of the age group. And the dose is 200 milligrams IV on the day 1, followed by the 100 milligrams IV daily for the 5 days. Lopinavir and the Ritonavir study published here that doesn't effective for people with a severe COVID-19. Favipiravir approved in India in June 2020. Monoclonal antibodies, immunomodulators, baricitinib. So that was also very popular at that time. Convalescent plasma, it's a double-edged weapon. Some says it's good, some says it's not that useful. But maybe considering the patient with a moderate diseases who are not improving, oxygen requirements is progressively increasing despite using the steroids, there we use it as a plasma. ABO compatibility and the cross-matching of the donor should be done. Use should be avoided in patients using IgA deficiency or the immunoglobulin allergy. Dose is variable, 4 to 13 ml per kg, usually 200 ml. Single dose given slowly over not less than the 2 hours. So that is the plasma. So here the indication is, in spite of your good steroid therapy, still the patient requires a lot of the oxygen. So then definitely there is a role of plasma therapy here. So this is an important drug, tocilizumab, may be considered in patients with the progressively increasing oxygen requirements. So in the place of plasma, you can try this tocilizumab. Long-term safety remains largely unknown. Carefully monitor the post for secondary infections and the neutrophilia, because once they are using it, so all the secondary infections will be flare up. The tuberculosis also will flare up. So these are all the things one should take care of. The active infections and the tuberculosis should be ruled out before the use, but we don't find much time here to get the all the things done. Dose is about 8 milligrams per kg. Maximum is 800 milligrams at one time. Given slowly in 100 ml normal saline over the 1 hour. Dose can be repeated once after 12 to 24 hours if needed. See, these are all the adult ICU case series. Common comorbidities like heart failure, COPD, diabetes, kidney injury, obstructive sleep apnea, obesity, etc. And complications, you will have the respiratory failure requiring the mechanical ventilation, shock, profuse shock, kidney injury, some people they require the dialysis also, cardiomyopathies, and bacterial co-infections. Here the mortality see 50 to 52%. Even in India, maybe 80 to 90% mortality in very severe cases occurred at that time. Several drugs under investigation at this time, like remdesivir, hydroxychloroquine, lopinavir, ritonavir, IL-6 blockers like tocilizumab. Steroids should be avoided unless indicated for the other reasons. See, most of the times, steroids are both underutilized or overutilized. So the clinical management is support to care of the complications. So these are the common complications: ARDS, pulmonary embolism, deep vein thrombosis, myocardial ischemia, cardiac arrest, myocarditis. A lot of the people who used to see myocarditis and cardiac arrest following these severe cases. In CNS, delirium, viral encephalitis, diffuse leukoencephalopathy, microhemorrhages, cryptogenic or ischemic strokes, bacterial pneumonias, MODS. So these are all very important complications of these therapies. Same thing here. So here the 47-year-old man with a 7 days history of upper respiratory infections, 3 days of worsening the dyspnea, hypertension, obese at the BMI 36, and diabetic. Non-smoker. Home medications, lisinopril for his hypertension, hydrochlorothiazide, and carvedilol, the beta blocker. At the time of the presentation, he was not tested for the COVID-19. See the pictures here. So it's a very typical of your COVID pictures. Okay. So the peripheral lesions, lower lobes, intubation and institution of the lung protective ventilation from day 2 through day 14, prone hospitalizations, ceftriaxone and azithromycins. Then they used the remdesivir, were given for 10 days course, hydroxychloroquine. Then luckily, weaned to the room air, significant neuromuscular weakness was developed on the day 21. So these are different findings, the lab finds. Significant weakness and the myopathy, remains hospitalized for more than 4 weeks after the admission. So once the more admissions means complicated DVTs, psoas hematomas and anticoagulation. COVID-19 testing remained positive even after the 3 weeks. On the 4th week, the test was negative and discharged from the hospital. So can pets at home spread the coronavirus? There is no evidence that companion animals or the pets, such as the dogs or the cats, can be infected with the new coronavirus. It's always a good idea to wash your hands with soap and water after contact with the pets. This protects you against the various common bacteria, such as E. coli and Salmonella, that can pass between the pets and the humans. Are antibiotics effective in preventing and treating the new coronavirus? No, antibiotics do not work against the viruses. They act against bacteria. The new coronavirus is a virus. Antibiotics should not be used as a means of prevention or the treatment. However, if you are hospitalized, you may receive the antibiotics since bacterial co-infection is a good possibility with a common comorbidities like diabetes, hypertension, etc. Does the new coronavirus affects the older people, or at younger people also susceptible? People of all ages can be infected by the new coronavirus, but people in the elderly population, more complications, more severity. So older people with pre-existing medical conditions appear to be more vulnerable to becoming severely ill with the virus. WHO advised the people of all ages to take steps to protect themselves from the virus, for example, by following the good hand hygiene and good respiratory hygiene. Are there any specific medications to prevent or treat the new coronavirus? No specific medicine recommended to prevent or treat the new coronavirus. Those infected with the virus should receive the appropriate care to relieve and treat the symptoms, and those with the severe illness should receive the optimized supportive care. Some specific treatments are under investigation and will be tested through the clinical trials. WHO is helping to accelerate the research and development efforts with a range of the partners. So I stop here. Thank you very much for your patient hearing.